Good evening, everyone. Mingalabar. My name is Sudasamons, Training and Education Manager from Medtronic, Thailand. Welcome you all to Liver Surgery Masterclass webinar series under Yangkong Specialty Hospital and National Cancer Institute collaboration. Before we start, please be informed that if you log in as a participant, you will only see your name and panelists, and your line will be muted to avoid distortion. But you still can ask your questions by typing your questions via Q&A box. And chat box is for general communication such as greeting or suggestions. This webinar will be recorded, and for privacy and disclaimer, we have requested all participants please do not take photo, screenshot or record this webinar. Thank you. Today is a great honor to have two privileged moderators, one from Myanmar and one from Thailand. Please welcome our moderators.
Thank you very much for that introduction.
Good evening, everyone, and all attendees from Myanmar. My name is Dr. Nunruthai Olanaparai, National Cancer Institute, Thailand. I will be the course moderator for today's session with Dr. Papa. Hello, Dr. Papa. Mekong Batala. Okay. Dr. Papa, but before we start this webinar cannot be happen if we don't have the one discipline introduce this course. So I would like to invite Professor Ravisak Janwat. He is the course moderator and chairman Department of Surgery, NCI, Thailand. He will give us the opening speech. Dr. Ravisak, please.
Thank you, Dr. Nup and Dr. Papa, dear Professor Emon, Professor Momotin, Professor Timpinma, and all participants. First of all, as Dr. Papa said, as we look back on February 2020, the first Yangkong Specialty Hospital and NCI collaboration meeting in Lab Liver Surgery 2020 under the topic of fundamentals in lab hepatectomy, and MOU signing ceremony finished successfully with Brighton Future. Under the MOU between our institute, the academic exchange and support should be continued, having carefully reviewed the ongoing spread of COVID-19 and the necessity of offering a chance to learn and share the knowledge, we have decided to hold the meeting as a series of virtual congress. At this time, the committee bring up the topic of liver surgery starting from the left side. For the meeting, we have 5 speakers for both institutes to share their experiences. I hope this meeting will be a great opportunity for HPB and general surgeons to update their knowledge and skill of minimally invasive liver surgery. Last but not least, I would like to thank our partner, Medtronic Company, for their great support and organizing this meeting. Before we start, I will show the video of the activities of our unit. Please enjoy our video.
สถาบันมะเร็งแห่งชาติกรมการแพทย์หนึ่งในสถาบันชั้นนำด้านการรักษาโรคมะเร็งโดยวิธีการผ่าตัดคงเป็นวิธีการรักษาหลักที่หวังผลในขาดได้ในการรักษามะเร็งหลายระบบมะเร็งของระบบตับอ่อนและทางเดินน้ำดีเป็นปัญหาที่สำคัญและพบได้บ่อยการผ่าตัดโดยวิธีการส่องกล้องในผู้ป่วยมะเร็งระบบนี้ให้ผลการรักษาที่เทียบเท่าหรือดีกว่าการผ่าตัดโดยวิธีการเปิดผนังหน้าท้องเช่นการเสียเลือดขณะผ่าตัดน้อยกว่าผู้ป่วยฟื้นตัวได้เร็วกว่าเจ็บแผลน้อยกว่าการวินิจฉัยและประเมินผู้ป่วยก่อนผ่าตัดเป็นหนึ่งในปัจจัยที่สำคัญมากที่ทำให้ผลการรักษาเป็นที่น่าพอใจ
การประเมินผู้ป่วยก่อนได้รับการผ่าตัดที่สถาบันมะเร็งของเราที่เราใช้นั้นเนี่ยมีอยู่2ส่วนครับส่วนแรกคือการตรวจวัด ICG ส่วนที่2คือการตรวจวัดปริมาตรของตับการวัด ICG นั้นเป็นการประเมินว่าผู้ป่วยรายนั้นเนี่ยสามารถตัดตัวตับได้จำนวนมากน้อยแค่ไหนส่วนการวัดปริมาตรของตับนั้นเป็นการวัดปริมาตรของตับส่วนที่เหลืออยู่ที่คาดว่าจะเหลือจากการผ่าตัดว่าเป็นปริมาณแค่ไหนการนำ2อย่างนั้นมารวมกันจะทำให้การผ่าตัดนั้นได้รับการปลอดภัยมากยิ่งขึ้นในสถาบันของเรานั้นเนี่ยการผ่าตัดที่ได้ประเมินทั้ง2อย่างร่วมกันนั้นพบว่ามีผลแทรกซ้อนจากการผ่าตัดเกิดขึ้นน้อยมากครับ
สำหรับเทคโนโลยีการผ่าตัดมะเร็งตับอ่อนด้วยวิธีการส่องกล้องนะครับในปัจจุบันนี้ก็ถือว่าได้รับความนิยมอย่างสูงแล้วก็เป็นมาตรฐานมากขึ้นนะครับส่วนเทคโนโลยีที่เราใช้ในสถาบันมะเร็งแห่งชาติเนี่ยอันดับหนึ่งเลยคือกล้องผ่าตัดของเราเนี่ยก็มีความคมชัดในระดับ 4K นะครับก็มีความละเอียดสูงมากทำให้การผ่าตัดเนี่ยสามารถเห็นเส้นเลือดที่อยู่บริเวณตับอ่อนได้ชัดเจนนะครับรวมถึงเรายังมีกล้องฟลูออเรสเซนต์นะครับสามารถดีเทคสารอินโดไซยานีนกรีนนะครับซึ่งเมื่อเราใช้ร่วมกับการใช้อัลตราซาวด์ในระหว่างผ่าตัดเนี่ยทำให้เราสามารถผ่าตัดตับอ่อนได้อย่างปลอดภัยแล้วก็ได้ขอบเขตการผ่าตัดได้ดีครับรวมถึงสามารถดูได้ว่าม้ามสามารถเก็บได้หรือไม่นะครับซึ่งถ้าคนไข้สามารถเก็บม้ามหลังจากการผ่าตัดตับอ่อนไปได้เนี่ยก็ทำให้ความเสี่ยงในการติดเชื้อรุนแรงหลังจากการผ่าตัดเนี่ยลดน้อยลงทำให้การผ่าตัดตับอ่อนเนี่ยมีความปลอดภัย
สำหรับ IORT หรือ Intraoperative Radiation Therapy เนี่ยเป็นเครื่องมือที่ใช้ในการฉายรังสีทันทีหลังจากที่มีการผ่าตัดเอาเนื้องอกออกจากตัวผู้ป่วยแล้วเป็นการฉายรังสีครั้งเดียวในปริมาณที่มากเพียงพอโดยมีผลกระทบต่ออวัยวะข้างเคียงค่อนข้างต่ำโดยเราจะเลือกใช้ในกลุ่มผู้ป่วยมะเร็งที่มีการลุกลามไปที่ต่อมน้ำเหลืองหรือหลอดเลือดบริเวณใกล้เคียงค่ะอีกหนึ่งเทคโนโลยีที่ใช้ในผู้ป่วยที่ไม่สามารถเข้ารับการผ่าตัดได้ซึ่งก็คือ IRE เป็นเครื่องมือทางการแพทย์ที่ใช้ในการทำลายเซลล์มะเร็งโดยอาศัยคลื่นไฟฟ้าไปทำลายเซลล์มะเร็งทำให้เกิดรูขนาดเล็กอย่างถาวรจึงทำให้ตัวเซลล์มะเร็งนี้เสียสภาพไปในที่สุดซึ่งวิธีการรักษา IRE นี้จะไม่ทำให้เกิดความเสียหายต่อเนื้อเยื่อบริเวณใกล้เคียงมีบาดแผลขนาดเล็กการฟื้นตัวของผู้ป่วยเกิดขึ้นในระยะเวลาอันสั้นค่ะ
นอกเหนือจากการรักษาผู้ป่วยแล้วการพัฒนาและถ่ายทอดองค์ความรู้ด้านการผ่าตัดรักษาโรคมะเร็งก็เป็นอีกหนึ่งภารกิจที่สำคัญของหน่วยมีหลักสูตรการฝึกอบรมศัลยแพทย์ผู้สนใจด้านการผ่าตัดตับโดยวิธีการส่องกล้องทั้งภาคทฤษฎีและปฏิบัติในสถาบันมะเร็งแห่งชาตินอกจากนี้ก็มีการออกหน่วยสอนและแนะนำการผ่าตัดในโรงพยาบาลศูนย์และโรงพยาบาลจังหวัดที่ต้องการพัฒนาการผ่าตัดตับโดยวิธีการส่องกล้องทั่วประเทศหากศัลยแพทย์ท่านใด ต้องการพัฒนาทักษะด้านการผ่าตัดโดยวิธีการส่องกล้องสามารถติดต่อมาได้ที่สถาบันมะเร็งแห่งชาติครับ
Thank you very much, Professor Ravisak, and your wonderful presentation. And he will be the speaker for the last topic today. Back to our session. We will start with the next topic, with principle of laparoscopic liver resection. We have Professor Tintin Ma. She is graduate on medical degree and surgical training program from University of Medicine 1, Yangon, Myanmar. And she also complete training in vascular and surgery from United Kingdom. Her current position is the head of HBPS at Yangon Specialty Hospital. Please welcome Professor Tintin Ma.
Good evening, my teachers, senior and junior colleagues from the Myanmar and Thailand. Today's webinar is the output of MOU from the NCI Thailand and Yangon Specialty Hospital, Hepatobiliary and Pancreatic Surgery Department. I'm Professor Tintema, Professor and Head of the Hepatobiliary Surgery Department. Today, I will talk about the principle of laparoscopic liver resection. The outline are as follows: introduction, patient selection, patient position, anesthesia and critical care, operative approaches, parenchymal transition technique, safety and efficacy, and final concentration. As we all know, minimal access surgery became the revolutionized modern surgery. Laparoscopic cholecystectomy became the standard procedure in 1990 and then moved to the hernia, spleen, gastric, kidney and colon minimal access surgery. For the laparoscopic liver resection, first reported cases was wedge resection for staging, hemorrhagic malignancy or isolated peripheral metastasis. After Turkey initiated series of laparoscopic liver resection for peripheral liver tumor, laparoscopic left lateral segmentotomy became standard of care. Then, Oraki reported a successful laparoscopic right hemi lobotomy, and Dagger confirmed that laparoscopic major hepatic lobotomy is safe and effective in high volume centered. So we can see there how progress of the laparoscopic liver resection from the 1992 to up to now. In 1992, start the first description of the laparoscopic liver surgery, and then in 2003 and 2009, because of the innovation and then the teamwork of the leading hepatobiliary surgeons from the 5 continents of the world, with their effort, description of the feasibility and safety we can confirm. And in the 2009 to 2014, laparoscopic liver surgery is better than open. We can raise this question. With these people effort, in 2014 and 2017, there was an era of consensus and guidelines. Now is when the minimally invasive approach is really needed for the laparoscopic liver resection. Let me start with the patient selection. It is critical because laparoscopic liver resection has the technically demanding, which needs the significant expertise in both hepatobiliary and pancreatic surgery and laparoscopy. How you select the patient? Our concern is polyhepatitis, underlying liver disease, disease distribution, tumor size, and coexisting pathology. Give me the same example. If the BMI more than 40, we have to prepare for the lung instrumentation. And if the case is there, fatty liver, fibrosis, and cirrhosis, at that time, we have to concern about the parenchymal transition. We have to choose of the electrosurgical instruments like the ligature. The case is benign or malignant because we have to consider about the tumor. clearance. It is bilobar because for the liver resection, before we liver reset, we have to concern about that is the FLR is adequate for the patient. Previously, for the laparoscopic for the liver resection, we are doing that is the size is there up to the 5 centimeter. Now we can do for the up to the more than 10 centimeter. But whenever you decide, you have to consider about that is a adequate functional remnant volume. Surgical margin at least 1 centimeter or greater. With the laparoscopic liver resection, we can manage the concurrent disease like the stomach, small bowel, and colon. Laparoscopic liver resection has evolved successfully in the several advanced centers. I would say for safety, we have to follow the principle, but hepatobiliary and pancreatic surgery don't stay only in comfort zone, and we need the innovation for patients with the safety margins. Patient position is also the critical factor. There are French position, supine, and lateral decubitus position. As we all know, French position is surgeon stand in between legs, and others are surgeon stand either right or left. In supine position, we can do for the left lobe and right anterior setter and tunnel technique for right hepatic vein. With the lateral decubitus position, right posterior setter and right hepatic vein can be handled. Hand-assisted device would improve the mobility of liver and aid in the dissection, but smaller feet to dissect is the one limitation. Without improvement of the anesthesia and critical care, without help of the anesthesia and critical care, liver resection cannot be done safely. In the past, perioperative mortality for liver resection was 30% because of the intraoperative hemorrhage and postoperative liver failure. But in 1980 and 1990, survival began change because of improved comprehension of hepatic anatomy and volume dilutions. Anesthetists maintain the CVP 2 to 4 millimeter mercury and blood pressure monitoring with arterial line and use of the vasoactive drug to minimize the hepatic ischemia. These are very helpful for the laparoscopic liver resection. By using the DEG, we can minimize the transfusion-related coagulopathy. So that's why understanding of liver pathology, complication, and treatment is important in all the team of the laparoscopic liver resection. Let me move to the operative approaches. There are poor laparoscopic approach and hand-assisted approach, and hybrid resection and robotic resection. When we do the laparoscopic liver resection, we need the low volume pneumoperitoneum, 10 to 12 millimeter mercury. I will explain in the next slide how we use the low volume pneumoperitoneum. But in case of venous oozing, we can up to the 14 to 16 millimeter mercury for a temporary period. Poor laparoscopy approach is the principal operative approach because it has the greatest challenge, ability to control the major hemorrhage. Anterior approach is the hepatic transition prior to lobar mobilization. Advantage is to prevent the tumor embolization resulting in the superior oncological procedure. Hand-assisted laparoscopy has the advantage of the tactile feedback, digital control of the hemorrhage, and ability to manipulate to the liver. But sometimes we can obscure our vision. Hybrid resection is the mobilization by laparoscopy and transition through the small open incision. Robotic resection has the similar oncological outcome with the laparoscopic liver resection, but it has the greater challenge, steep learning curve required for the robotic placement, and ability to rapidly unlock and roll off the robot in case of emergency. It is complexity and time consuming. Parenchymal transition technique can lead to the hemorrhage and convulsion. There are two techniques, electrosurgical dissection and stapler hepatectomy. Electrosurgical dissection include CUSA, harmonic scalpel, ligature, bipolar cautery forceps, suction tube with the blood tape, dissector, graspers, and liver retractors. We need to use both hands and activation with both feet simultaneously. Whenever we do the parenchymal transition technique, we should inspect the IVC, which should not be distended. And then after control of the pedicle, we have to find out the resection line and follow the resection line. Incision of the glycerin capsule would be done by the CUSA and bipolar. So the active blade of the ultrasonic dissector is introduced into the liver with the half lamp we can see in the picture. For the deeper parenchymal transition, tissue dissection and hemostasis would be performed by the CUSA or harmonic and bipolar retraction and rescue hemostasis. For the cirrhotic liver cases, we should use the ligature. The large branches, we need to use the surgical clip or suture ligation, and for the trunks of the hepatic vein, linear stapler, white cartridge should be used. You can see the two hands, we use the ligature and bipolar. You can see in the picture during the hepatic parenchymal transition. Complete hemostasis before dissecting any further. This is the important point. So, most bleeding control with the bipolar, 40 watt initially. If it is bleeding is continued, we should better to decrease the watt and device kept to activated until the tips are fully removed from the clot. Stapler hepatectomy is in division of the right portal triad in fibrosis and cirrhosis cases. So, for the laparoscopic liver resection in cirrhotic patient, liver-related criteria, tumor-related criteria we should consider. For the liver-related criteria, liver cirrhosis position should be compensated. How can we know they're compensated? Esophageal grade less than 1 and platelet count should be more than 80. Tumor-related criteria, in the cirrhotic patient, we should choose the size of the tumor is less than 5 cm and well clear from the portal pedicle or hepatic vein and distance from the transition line. These factors are very important. So by choosing them properly, if we do the patient selection properly, we can get the less bleeding and less blood transfusion. It leads to the less recurrence. So we have to concern and we have to decide which you will do, anatomical resection or parenchymal sparing resection. It is the case by case decision. Let me move to the safety and efficacy. So the problems are gas embolism, hemorrhage, and open conversion. So for the gas embolism, because of the significant disruptions of the hepatic vein at their origin. So in that time is to avoid argon gas into the bleeding major hepatic vein brush and use of the intraoperative transesophageal echo for early detection in the large resection cases. By doing this, we can prevent the gas embolism. And then I already present, we need the low pneumoperitoneum 10 to 12 mm mercury. It also prevents the gas embolism. For the hemorrhage, anesthetists help with the low CVP, and then we use the routine use of the bottle inflow control, 15 minutes and 5 minutes interval, and quick stitch and hemostatic biological agent like the bioglue or sealant. That patient safety is the most important point. So if you are not safe or if there is no progress of the laparoscopic liver resection, we should convert to the hand-assisted approach and then to the open conventional one. As a complication of laparoscopic liver surgery, bionic and myeloma is 3 to 5%, morbidity is 12 to 18%, mortality is 0 to 3%, and laparoscopic liver resection rate is 20 to 65%. But in the higher center, the resection rate is up to the 80% of the total resection rate. So laparoscopic liver resection shows survival compatible with the open with the additional benefits: decreased post-operative pain, shorter hospital stay, lower blood loss, and decreased adhesion formation. There are the final considerations. Evolved rapidly over the last decade, but it limited to the widely acceptable procedure to the major recessions. It should only be pursued with adequate expertise to hepatic resection and laparoscopy. It should begin with the left lateral and minor recession, then move to the major recession, and then the living donor hepatectomy. Stepwise approach is the safest one. It is feasible, safe, and result improve with experience. Repeated laparoscopic liver resection can be performed also, but still pending for justification of the long-term survival. So we have to keep in mind of that patient safety and innovation for the hepatobiliary patient. And then another balance is what is the instruments available and standardization of the operation. Thank you.
Thank you so much, Professor Tintin Ma. I think I've got many useful details for learning and improve my technique in laparoscopic liver resection. Dr. Papa, I think you are very lucky to have the chance to learning directly from the expert surgeon.
Yeah, sure. I'm really very happy to work for her also. Yeah, I have no words to express my gratitude. Really. Okay, so let me move to the next speaker. She is a beautiful lady surgeon from National Cancer Institute. So you know who she is? Yeah, of course she is Dr. Mook. She is my co-moderator. She graduated from Prince of Songkla University, Thailand in 2010, and then she took the Thai Board of General Surgery in 2014, and she completed her clinical fellowship in hepatobiliary pancreatic surgery at the Department of Gastroenterological Surgery, Tokyo Women's Medical University, Japan in 2019. She is currently working in hepatobiliary surgery unit, Department of Surgery, National Cancer Institution, Thailand. Today, she will be talking about surgical anatomy of the left liver. So may I invite Dr. Luke to give a talk? So Dr. Luke, please.
Thank you, Papa, for the introduction. So good evening, everyone, and all attendees from Myanmar. My name is Dr. Nungruthai Oranaparai from National Cancer Institute, Thailand. You can call me Nook because it's easier. Today, I have the great time to share within surgical anatomy in laparoscopic left lobe liver. Laparoscopic liver surgery has evolved over the past decade and nearly replaced the open surgery. Many of the challenges in laparoscopic technique that could be limit development has been overcome through by the new instrument and many modalities. For example, The ICG pre-operation for evaluate the exactly allowance hepatic resection, or the ICG fluorescence for intraoperative to evaluate the tumor location, the demarcation, or the bile duct anatomy. Preoperative evaluation about the exactly surgical liver anatomy and relevant vasculobiliary system are the important steps to make a safe surgical planning for our patients. Due to our topic sessions today about laparoscopic liver surgery starting from the website, I will focus on the important anatomical landmark issue of the left lobe liver, which following in this outline. We will see the liver from caudal direction in laparoscopic view, which is difficult for dissection and mobilization from surrounding structure, but it will be easier to approach the hyaline structure from this view. In the radiological study from Italy, the morphological of left lobe was classified as classical when the left lobe liver show a shape of equilateral triangle in the axial image, small when the left lobe liver did not exceed the median line in the axial view, elongated when the left lobe show a shape of as isosceles triangle in the axial view and past the midline, rounded when the edge of the left lobe show a curvilinear shape in the axial image. The important plate for the left side liver is the Allansius plate, the hilar plate, and the umbilical plate. The umbilical plate is on the inferior part of ventral surface of the umbilical fissure, which connect to the root ligament. We use left side of it to be the landmark for start the parenchymal transection in left lateral sectionectomy. If we go back in fetal periods, the ductus venosus, which is between umbilical portion of the left branch of the portal vein to the IVC, and runs from the ventral side of umbilical portion. It was shunt the oxygenated umbilical cord blood away from the liver. After delivery, this ductus venosus was obliterated and left us with the ligamentum venosum or the Allansius ligament. The Allansius ligament found as a band structure on the anterior surface of the spigal lobe. If we divide the left coronary, triangular, and gastrohepatic ligament and mobilize the left lobe liver to the right side, we will see the area of Allansius plate. Even though the valuation of vascular and biliary system will less effect to the Grisonian technique for left hepatectomy or left lateral sectionectomy, but in case of intrafascial technique, the possibility to know pre-operative, the number and the location of collateral branches can be useful to the surgeon to avoid damage of segmental vessels. First organ that play as one important inflow part is the portal vein. The portal vein divides into right and left branch at the hilum. The left portal vein usually lines more horizontally than the right portal vein and show a small caliber. It is divided into two parts, the transverse and the vertical or umbilical portion. The transverse portion around 4 to 5 cm in length run along the base of segment fold and often given branches to segment 1 from dorsal side and sometimes to segment 4. The branch to segment 2 continues laterally in respect of umbilical part, whereas this part takes a more anterior and vertical course in the umbilical fissure, where it gives branches to segment 3 and 4 and receive the obliterate left umbilical vein. The anatomical variant of the portal vein occur approximately 20% of cases. Variation usually involved the right portal vein. Absence of a right portal vein with resulting portal trifurcation, left, right paramedian, and right lateral portal veins is present in 10 to 15 of the liver. Occasionally, the right paramedian vein arises from the left portal vein, a variant which is important to consider when planning left hepatectomy. The important notice is when you cannot find the main right portal vein, which divide to right anterior and right posterior, you should re-evaluate it carefully about the variation of portal vein before the operation. The confluence pattern of bile duct in the left lobe that were mainly classified as A. The common trunk of B2 and B3 joins to B4. B. Triple confluence of B2, 3, and 4. C. B2 joins the common trunk of B3 and B4. We still evaluate the variation between bile duct and portal vein. We can divide to supraportal type, which is more commonly as in this picture. Another variation that affects to the left hepatectomy or left lateral sectionectomy is the pattern of the hepatic artery in the hilar area. A. The most common type in which the right, middle, and left hepatic artery arise from the common hepatic artery. B. A type in which the left hepatic artery arises from the left gastric artery. C. The type in which the right hepatic artery arises from the superior mesenteric artery. When the left hepatic artery arises from the left gastric artery, that will be affect to left hepatectomy or left lateral sectionectomy. If we don't know about this variation before, we will not ligate the left hepatic artery. That will be the cause of excessive bleeding during parenchymal transection, even perform the Pringle maneuvers, or misunderstand to injury to middle hepatic artery or right hepatic artery. In the hepatic venous system, we can find the umbilical fissure vein, which runs along umbilical fissure that is located between left and middle hepatic vein. The variation is dependent on the joining to left hepatic vein, which more common about 90%, or join with middle hepatic vein about 7%, or join at bifurcation about 3%. When we have a knowledge, let me sharing some experience by clinical usage, the landmark anatomy. From knowledge that the Allanchius ligament is on the fossa between the spigal lobe or the left side of caudate lobe and left lobe liver. If we can select the left pedicle just beyond this Allanchius ligament, we will dissect and ligate the left pedicle without damage to the caudate branch. The trick is we will not touch Allanchius ligament or any structure that lower than Allanchius ligament when we perform to ligate the left pedicle in left hepatectomy. Since the surgical landmark is the middle hepatic vein for left hepatectomy, the transection will trace the tributary of the middle hepatic vein cleanly to reach the trunk of the middle hepatic vein or common trunk at the caval insertion. The tributary of middle hepatic vein are V4A, V4B, or the umbilical fissure vein. If we know pre-operation that our patient has a variation about middle hepatic vein or its tributaries, such as the umbilical fissure vein joining, we will perform with meticulously, oncological, and bloodless. In conclusion, to surgically manage successfully, it is very, very, very important to be familiar with the principal anatomical variations of the biliary and vascular components of the prey system in the hepatic hilar area. Thank you for your attention.
Thank you very much for your very informative and useful presentation. As we all know, hepatobiliary system is the one which has a lot of variations, and we encountered a lot of different challenges in day-to-day basis. So really thankful for your informative presentation, and I really want to know how the next speaker will make good use of your clinical anatomy, and we were really curious to know. So please go ahead.
Thank you, Dr. Papa. For the next topic with laparoscopic left lateral sectionectomy, we have Dr. Chairat Bunchariao. He was graduated medical degree from Chulalongkorn University, Thailand. He got surgical training program from Prince of Songkla University, Thailand. His current position is the head of HPB unit at National Cancer Institute, Thailand. Dr. Chairat, please.
Laparoscopic left lateral sectionectomy. In the Louisville statement in 2014, laparoscopic liver resection was considered a standard practice for liver tumor located in the left lateral sector. However, due to the lack of the strong evidence in case of HCC, this recommendation was not strongly supported by the Morioka consensus. Many recent retrospective and meta-analysis from around the world demonstrate their long-term outcome for HCC. In their study, laparoscopic left lateral sectionectomy resulted in survival comparable to conventional open approach. Only one but not good quality RCT for the HCC reported that the laparoscopic is better or comparable for the open surgery. For the disease-specific indication, benign lesion became clear on advantage compared with open technique, supported by the consensus from Louisville and Morioka. Report of Oslo Comet trial in 2018 confirmed short-term outcome of laparoscopic over open surgery for colorectal liver metastasis. As I mentioned before about HCC, even the RCT quality is not good, but the result from the meta-analysis and retrospective data favor the laparoscopic over the open. All these three indications now clear for favor laparoscopic surgery. For the controversial group, data from the ICC, living donor liver transplantation and bilobah disease still limited. However, the meticulously selection of the patient with this indication is reasonably possible, and laparoscopic should no longer represent a general contraindication. For the giant tumor, many issues must be concerned. The Tokra position, liver mobilization, accidental tumor rupture event, the long incision is required to retrieve the specimen. All these issues make the open is better than laparoscopic. Finally, for the redo operation, extensive adhesion often require acidolysis for several hours and possible for multi-organ injury. This factor can limit the laparoscopic approach, but you can try laparoscopic first with open surgery as your backup plan. Step of operation should be followed. The first, I would like to talk about the general and anatomical consideration, then the patient and trocar position, followed by parenchymal transection, and the last about pedicle and hepatic vein transection. Left lateral section is thin when compared to the right side, and it contributes 15 to 30% of total liver volume, making post-hepatectomy liver failure an unusual occurrence. But please carefully check for the ICG every time when the patient had the cirrhosis. For the example, this patient left lateral sector volume is 18% of the total liver volume, which is segment 2 about 8% and the segment 3 about 10%. From the laparoscopic view, the resection should preserve umbilical portion and umbilical fissure vein. Only 3 structures should be transect, including of the segment 3 pedicle, segment 2 pedicle, and left hepatic vein. This is anatomical structure on the top of liver, which is opposite to the endoscopic view. Patient can place on supine position with split leg. Surgeon standing between the patient leg, camera holder and the assistant standing on the right side of the surgeon. Camera trocar should be placed at the umbilical area. Surgeon trocar including 12mm and 5mm should be placed on right and left subcostal as figure. The main 12mm trocar should be placed along the transection line. Another two optional trocar can be placed on the right and left side of the patient. The right optional trocar can be used for traction the liver, and the left optional trocar can be used for extracorporeal Pringle maneuver. For the superficial layer, electrocautery or harmonic scalpel can use to create the transection line, and for the deep part, QSA should be the good option for dissection and transection. For pedicle and hepatic vein transection, in some cases you can use 60mm staple for make a single transection as a figure, but I do not recommend this method. You should transection the pedicle of segment 3 first by using 30 or 45mm staple, then transection the parenchyma to identify the segment 2 pedicle. Please be careful in the area that segment 2 pedicle crossing with the left hepatic vein. Do not find the staple here because of the staple may not secure these two structures together. Placing the staple here is safer, or you can perform the individual ligation of each structure. I have one case demonstration for you can understand the surgery. The patient is a female, 67 years old. She was diagnosed with chronic HPV infection with liver cirrhosis for years. This imaging of this year finding HCC at the segment 3. We plan to perform the laparoscopic left lateral sectionectomy for this patient. For the evaluation process, she got a CPTA, ICG 14, AHR is 52%, FLR is 63%, and the liver combined test is 115, which passed the test. You can see the liver is quite cirrhotic. First, we transect the falciform ligament. Then the suprahepatic IVC was dissected. Left liver was mobilized. Then the liver was hung up to expose the hilar area. The hilar plate was taken down by electrocautery. Dissection to identify the gap between the left and right pedicle. The endo-bulldog clamp was used to perform the inflow control of the left liver. You can see the demarcation line of the left liver. Traction and counter traction is the key for success operation. The superficial layer of the liver was transected by harmonic scalpel. The resection line was drawn to the left hepatic vein origin. For the deeper part, we usually use a QSA for the dissection and transection. The branch of segment 3 was identified. The hemorrhage clip was used. Then the vessel sealing device was used to secure the transection. This section continued higher up to identify the umbilical fissure vein. As you can see, this is umbilical fissure vein. By dissection following this vein, you can find the left hepatic vein. This is the junction that the umbilical fissure vein drains to the left hepatic vein. This section above the area of the left hepatic vein to encircle the vein. Sometimes you encounter with the left superficial vein. Please be careful to ligate this vein every time. The left hepatic vein was dissected and encircled. The first stepper was placed to transect the segmentary pedicle. Then the left hepatic vein was double ligated and then transected. Continue dissection after you transect the left hepatic vein to identify the remaining segment 2 pedicle. The second stepper was used to transect segment 2 pedicle. Now the operation was finished. For the conclusion, laparoscopic left lateral sectionectomy is a safe and feasible procedure for benign lesion, colorectal level metastasis, and HCC indication. But the risk of the surgery must always be assessed on the basis of the surgeon's own learning curve and individually weighed against the potential benefit for the patient. As some limitation of the minimally invasive technique will likely remain in the foreseeable future, open surgery can only be supplemented but not replaced. Thank you for your kind attention.
Thairat, for your wonderful and nice video presentation. I have learned many things about the anatomical follow after the surgery in laparoscopic left lateral sectionectomy. I think it was very useful for the starter or the young surgeon to learning about the start of the laparoscopic liver resection. So the next there will be the medical Medtronic video presentation.
and it is about the Medtronic innovations. Let's see the presentation.
Since it first appeared 2.5 million years ago, the human brain has become the most complex object on the planet. Billion neurons, 100,000 kilometers of interconnections, making us faster and smarter. Now, an even faster, more efficient source of intelligent power is available in the operating room. The fourth generation of ligature technology. The Valley Lab FT10 Energy Platform. Everything with the FT10 has changed for the better. Everything is easier. Simple user interface makes it easier for nurses to operate. Precise energy delivery allows the use of lower power settings. Upgrade to the latest software at the touch of a button. Everything is faster. Vessel sealing times are up to 50% quicker. Auto bipolar activation time is faster and more consistent. Immediately detects presence of clips and staples in the jaws of the device. Ligature jaw temperature remains lower. Everything is smarter. Tissue effect sensing technology precisely adjusts the energy 434,000 times per second. Thermal spread to surrounding tissue is minimized. The Valley Lab FT10 Energy Platform not only drives our full portfolio of energy-based devices, it makes them better than ever. Switch on to the new Valley Lab FT10 Energy Platform. It changes everything.
So I would like to thank you Medtronic for your kind support for this wonderful webinar meeting, and then we will move on to our next speaker, Dr. Papa.
Sure. Why we should wait for next speaker? We're really moving for. Okay. So next speaker will be Dr. Rafifat. Dr. Rafifat graduated from Chulalongkorn University, Thailand in 2002. And he passed the Thai Board of General Surgery in 2009. And he completed his clinical fellowship in bariatric and plastic surgery, minimally invasive surgery unit, King Chulalongkorn Memorial Hospitals, Thailand in 2017. And he is currently working in Department of Surgery, National Cancer Institution, Thailand. So today he will be presenting about laparoscopic left hepatectomy. So may I call upon Dr. Rafifat to present his lecture. So, Dr. Rafifat.
Hello, good evening everyone. My topic today is laparoscopic left hepatectomy. I will talk about anatomical consideration, port and trocar position, inflow, outflow control, liver parenchymal transection, and video presentation. 5 years ago, the international consensus in Morioka indicate that minor laparoscopic liver resection is confirmed to be a standard practice. But major operations such as laparoscopic left hepatectomy are classified as innovative procedure. Afterward, there are many case series has been continuously reported. The journal was publication in Surgical Endoscopy 2017 from HBB surgeon in France. 27 cases after laparoscopic left hepatectomy show the good result. Short hospital stay, no mortality, and no liver fluid in this literature. So they conclude that laparoscopic left hepatectomy seems safe and feasible when performed by experienced surgeons in both laparoscopic and liver surgery. In this literature, multi-center case control study compare between laparoscopic lateral sectionectomy and laparoscopic left hepatectomy. Laparoscopic left hepatectomy seems to have more operative time estimated by loss blood transfusion and length of hospital stay than laparoscopic lateral sectionectomy, but in the oncological outcome and morbidity is comparable. So they conclude that laparoscopic left hepatectomy is more technically challenging and time-consuming than laparoscopic lateral sectionectomy, but it seems safely and efficacy in expert HB surgeons in specialized center. For the important anatomy, the left hepatic duct usually longer than the right hepatic duct, so if you lowering the hilar plate from the corded rope, you have space allowed 3 cm for a precam to perform the left pedicle control. For the anatomical variation of the portal vein, sometimes right anterior segment of the portal vein is joined with the left main portal vein. And for the hepatic duct variation, if the patient absent of the right main intrahepatic duct, sometimes right anterior or right posterior intrahepatic duct is joined with the left main intrahepatic duct. That you should do the MRCP, especially when the patient absent of the right main portal vein or absent of the right main intrahepatic duct for no this atypical structure. For the artery variation, accessory left hepatic artery was alive from the left gastric artery up to 12%. So when performed Sprinkle maneuver aim to occlude hepatic inflow is still bleeding until you clamp this artery. For the patient positioning, this picture shows patient is in the lithotomy position with head up and right side up. It helps decrease venous pressure and improve exposure by gravitationally shifting visceral structure away from the liver hilum. The surgeon stands between the leg and the assistant surgeon and cameraman is on the left side of the patient. For port and trocar position, in our technique we usually use 5 ports, same as laparoscopic right hepatectomy. Patient must be already placed in the reverse Trendelenburg positioning and right side up before we made the port incision for the proper port and trocar placement. In the liver mobilizationing technique, first the ligamentum tertius is secured with the bipolar device. The falciform ligament is divided backward to the liver down, then you can expose the major hepatic vein and suprahepatic IVC. We recommended to do the suprahepatic dissection by medial to lateral approach that can prevent injury to the major hepatic vein and IVC that I will show in the video later. For the info control or major hepatectomy, we always perform Sprinkle maneuver by extracorporeal fashion. After encircle hepatoduodenal ligament, we do left portal pedicle control by Gistonate approach. Foresee the demarcation line between right and left lobe liver. The parenchymal transection pain, we usually perform dissection by follow median hepatic vein as landmark. It can be the marginal line for tumor resection margin. If we follow the median hepatic vein, we can avoid injury to the portal pedicle and preserving venous drainage of the main segment. For the outflow control, common trunk is almost present up to 96%. So it's safe for secure left hepatic vein after parenchymal transection because you can see it take off from the common trunk clearly before apply vascular stapler. The case presentation is Thai male, 70 years old, presenting with the epigastrium mass with the abdominal discomfort, non-hepatitis B and C infection, rising alpha fetoprotein. The MRI with pyemovis show typical hepatocellular carcinoma. There is a arterial enhancing mass, wash out in the delay phase, and no pyemovis uptake. The size up to 10 cm at the left lateral lobe of the liver. This picture shows the port positioning in this patient. The general exploration, you can see the tumor at the segmentary of the liver. The falciform ligament was taken down. Then pull the liver down and perform suprahepatic dissection. Medial to lateral approach fashion. So in this area, we recommended to use the bipolar device. Now you can see the common trunk and left inferior phrenic vein. Then track the lever up to access the foramen of Winslow and perform encircle of the hepatoduodenal ligament by cord tape. Ringen maneuver was performed before take down the HILA plate. In this area, we use a low energy device and cut 2 mm away from the visceral perineal reflection for detached HILA plate from liver parenchyma. In this case, we found the vessel that connect to the HILA, so we have to divide it before complete this step. After complete isolation this vessel, then the vessel was clipped and sealed with bipolar device. Small vessel that coming from the left pedicle was sealed with bipolar device. The vessel that feed the tumor was isolated, double clipped and divided. Because the tumor in this case is very big and obstruct to X-post or the Allen-Sheath plate, so in this case we use temporary info control or trigger technique. When the posterior margin of the left portal pedicle was visualized, the left portal pedicle was occluded by endobuttock clamp. The demarcation line was seen. The demarcation line was marked with electrocautery. The finishing point is at the right side of the left portal pedicle that we apply the endobuttock clamp, and the right side of the left hepatic vein. Superficial parenchymal transection was performed by ultrasonic device. For the dorsal side of the liver, we use the QSA for prevent the middle hepatic vein injury. For the deep liver parenchymal transection, we use QSA for individualized selective control the small vessel and small pedicle. Now you can see the middle hepatic vein. That means you are lucky today. We use middle hepatic vein as an intrahepatic landmark, guide us for keep the right plane. Don't be cut the small branch of the middle hepatic vein earlier. Use them to follow and find the main branch. Then V4 was clipped and sealed by bipolar device. There are usually no branch of the middle hepatic vein trunk at the ventral side. So we keep dissection at this plane. After clearly isolation, V4B was clipped and sealed by bipolar device. V4A was double clipped and sealed. We follow middle hepatic vein until it joins at the IVC. After that, the transection plane was kept down, ventral and left side of the arranged plate. In this case, we used the endomini retractor for isolated the left portal pedicle. The vascular stapler was applied. The transection line kept above to the arranged plate for prevent to injury to the caudate duct. Now the left hepatic vein was identified. We used the QSA remove the liver parenchyma enough before we apply the vascular stapler. The liver capsule and adhesion at this area was sealed by bipolar device. After isolation left hepatic vein, then left hepatic vein was sealed by vascular stapler. At this step, the transection line was kept away from the IVC and make sure that not injury to the middle hepatic vein. Laparoscopic left hepatectomy was done. Now you can see the good left hepatic vein stump, good blood flow in the middle hepatic vein, and we can preserve the caudate duct. The operative time is 4 hours 30 minutes. Estimate blood loss 100 cc, no blood transfusion, no post-operative complication, and the patient discharged at the post-operative day 5. The pathological report that a tumor is a moderately differentiated hepatocellular carcinoma with the lymphovascular invasion positive and free resection margin. The picture shows the abdominal scar when patients come to see me at the OPD. Conclusion: laparoscopic left hepatectomy was safe, feasible, and technically challenging. Historian approach for the lab pedicle control and middle hepatic vein guide parenchymal transection is the success key. Transection plane must be keep ventral to the arranged ligament for prevent caudate duct injury. Thank you for your kind attention.
Thank you very much, Professor Dr. Rapipat, for your wonderful technique in laparoscopic left hepatectomy. I've got many ideas about how to prevent to injury the caudate branch or many techniques to dissection intraparenchymal hepatic resection. Okay, and for the next topic, okay, we will carry on to the last speaker. He is Professor Ravisak Janwat. With his topic is very interesting for our session. It is a do and don't technique in laparoscopic left lobe liver resection. He is our chairman of Department of Surgery, National Cancer Institute, Thailand. Please, Dr. Ravisak.
Thank you, Chairman, and good evening, all participants. In my talk, I will pick up the important point of the liver and the laparoscopic approach. I will focus on the three considerations. The first one is anatomical and variation, landmark and clinical usage, and technical consideration. Let me start with the anatomical and variation consideration. Begin with the inflow. The portal vein, hepatic artery, and bile duct were enveloped with a Grecian sheath, which we call Grecian pedicle. There are three levels of the pedicle. The first order branch level means that the pedicle that supply the lobar, right or left liver, and the second order branch level on the right side. There are two second order branch, right posterior portal pedicle and right anterior portal pedicle. For the left side, the second order branch transform from the transverse portion to be the umbilical portion at the insertion of Allan's ligament. And for the third order branch level, it means that the pedicle that supply each segment. Grecian pedicle is synonymous to the portal pedicle beyond second order branch level. There are frequent variations of the branches of the portal vein, hepatic artery, and bile duct crossing the boundary within the territories of first order branches. And we found that no variation of crossing the boundaries in the territories of second and third order branch. When applying Grecian approach, the ligation of pedicle must be performed at the level of second order branches or further, like this. These two figures is a good demonstration of the variation. The figure on the left side, you can see the variation in the first order branch boundary. The right anterior portal vein is arise from the left portal vein, and if we apply the staple during we perform left hepatectomy, you may injure or transect the right anterior portal vein. And the picture on the right side, the right posterior sectoral bile duct is drained into the left duct. So if we apply the staple at first order branch, of course you will transect the right posterior sectoral duct. There are various types of procedures on the left side of the liver. Non-anatomical resection or anatomical resection is composed of left hepatectomy, left lateral sectionectomy, bisegmentectomy 4B and 3 and segment 3, segmentectomy 2, 3, 4, 4A, 4B, and subsegmentectomy or cone unit which proposed by Professor Takasaki. This figure shows the one kind of anatomical resection by segmentectomy for segment 4B and segment 3. Grecian pedicles have a certain rules of variation within the liver parenchyma. I mean the third order branch with located inside the liver. The left lobe have variations only in the number of segmental pedicles, and that of the right lobe might have variations in both number of pedicles and sliding of origins. What is the sliding of the origins? The study from Korea group reviewed the sliding of origin variation of the right Christian pedicles. Figure A is no variation group. Figure B shows branch of S segment 5 originate from the right posterior pedicle, which means that if we perform right anterior sectionectomy in this group, the right hepatic vein does not run through the inferior or caudal area of the transection plane. We call this kind of variation is a posterior dominant variation. And in figure C, show branch of segment 6 originate from the right anterior pedicle. If we clamp the right anterior pedicle, the demarcation line will cross over the right hepatic vein trajectory. This information showed the fact that quinose segmentation does not reflect the anatomical and surgical territorial reality. The actual portal vasculature is more complex than quinose segment structure. I will introduce the three levels of complexity which proposed by Professor Marshall. The first level is identical to quinose 8 segment scheme, serve as a common language between clinicians. The second level is an anatomical level based on the actual branching pattern of Christian pedicle that allows surgeons to identify vascular structure by 3D image in modern liver surgery. Finally, the third level is a step for anatomists. The study from facet by inject the acrylic resin into the portal vein, and we found, or generally speaking, this figure illustrates the fact that there are not 8, but a higher number of segmental territories in the liver. For increasing demanding surgical procedure in liver surgery, likely to require increasingly accurate insight into vascular and biliary territories. Let's move to the landmarks and clinical usage. Anatomical keys and crucial structures when approaching hepatic veins are inferior phrenic vessel. This vein drains into IVC or right or left hepatic vein, so we can use inferior phrenic vessel to identify the main trunk of right or left hepatic vein. Allanchius ligament is another important structure for handling hepatic veins. Dissection of the Allanchius ligament usually make exposure and encirculation of left hepatic vein and the common trunk easier. In this figure A, the standard anatomy, the Allanchius ligament depicted by the black dot line and the gastrohepatic ligament by the gray foreground. For selective control of the left hepatic vein, the gastrohepatic ligament is preserved and the liver capsule is incised longitudinally at the level between the liver and the Allanchius ligament. For selective control of the common trunk, as picture C, the gastrohepatic ligament is sectioned and the liver capsule is incised longitudinally behind the Allanchius ligament, and the ligament and liver parenchyma are lifted up. The Allanchius ligament can be used as a landmark for left extrahepatic Christian isolation and as a guide for surgeons to achieve an optimal plane during left hemihepatectomy. This video demonstrates the Allanchius ligament as a landmark for left extrahepatic Christian isolation in open surgery. And this technique can be applied in lab surgery with special instrument. The fundamental landmarks to determine intersegmental sectional planes seem to be considered as the demarcation line, the landmark veins inside the liver, and the root of responsible Christian pedicle. Choose and contrast agents for surgical segmentation composed of IOUS with or without contrast agent, ICG fluorescence system, real-time navigation. For ICG staining method, the negative staining technique is found simpler and more feasible than the direct ICG injection into a portal vein branch, particularly in the setting of minimally invasive approach, as the injection method required to be mastered for ultrasound examination and a careful manipulation of the needle. The next consideration is a technical consideration. I have summarized the practice points for safe lap hepatectomy. Start with keeping a low CVP along with the pneumoperitoneum, offer a bloodless field, and allow for a safe exposure of the major veins. Before starting the transection, ultrasound helps to identify the major vein, for example, middle hepatic vein, which close to the hepatic hilum, terminal part of the left hepatic vein, so that it can be precisely and safely approached. Pringles tape should always be prepared. Its rapid use in case of bleeding can prevent a large conversion and avoid blood loss. It can be helpful in controlling oozings during the parenchymal dissection by increasing the pressure from 12 to 15 or sometimes 20. Always have the vascular clamped when using the staple device. The right or left portal vein must not be ligated before confirming the portal vein bifurcation. Major hepatic vein is exposed on the raw surface during major hepatectomy, also serves as the anatomical landmark for the direction of transection. A common disadvantage of lap liver resection for precise surgery are difficulties in generating an overview of the liver, difficulties with tactile feedback, restriction of manipulation, and technical difficulty in detecting the required hepatic segment when using a positive staining method. It is important to expose the hepatic veins as one of the landmarks for the parenchymal transection in order to prevent disorientation, since the hepatic veins often run between the borders of liver segments. This conceptual basis is the same as for open liver resection. There are two main hepatic vein approaches. The first one is from the root to the peripheral side of the hepatic vein. The main advantage of this approach is to avoid splitting the venous bifurcation, which can cause severe bleeding at the confluence of the hepatic vein branches. And the second approach is the periphery to root approach. Use the benefit of lab-specific view in terms of caudal approach. Some experts recommended the tips on movement of the CUSA device that they recommend to move from the back to the front. This video is lab segment 4 resection. This video I will show the technique to approach the middle hepatic vein from the root side. I usually perform Pringle maneuver in the major liver resection. We can perform intra or extracorporeal Pringle maneuver. During we cramp the inflow, we can dissect the hilar and can create the Bartlett field. You can see the vascular gap between hilar plate and the liver capsule. Then we apply the bulldog cramp to create the demarcation line. This is the right transection plane for the segment 4 anatomical resection. Ultrasound is useful to locate the tumor and correlated intrahepatic vascular structure. Then we start the first transection plane along the first form ligament, which we use as a surface landmark, and the dissection was performed deep to the umbilical plate. The dissection was go inside, and we found the G4 pedicle which directly feed the tumor. And we continue dissection until we found the root of middle hepatic vein. And then we use this vein as a boundary. Then the first transection plane was complete. We transect all of G4 pedicle. As I mentioned earlier, the variation of the tertiary branch on the right side is only the number of the pedicle. There are a lot of G4B and also G4A pedicle. In this case, I think up to 7 to 8 pedicle. After our pedicle was transect, we will flip the liver to the right side and detach the segment 4 from the hilar plate. Now we can see the landmark point, the hilar plate, the root of middle hepatic vein, and we already have the surface landmark of the second transection plane. And then we just connect all of the landmark together. It is important to master your dissection device at this. We use the technique of scroll down. If we export the vein from the root side, as I told you, you can avoid the avulsion or split injury of this vein. And the transection was complete. Another example of caudal approach, we usually transect the ventral and dorsal area of the parenchyma along demarcation line. The transection plane will look like convex shape. On the other hand, during we transect the dorsal part along the demarcation line, we may find the main trunk of hepatic vein, middle hepatic vein, which usually located nearby the hilum. So it's very useful if you place the ultrasound probe to check how deep and the location of middle hepatic vein at the hilar region, so you can approach it safely. In this approach that we call peripheral approach, it means that we dissect the vein from the periphery to the root. Now you can find the trunk of middle hepatic vein. In conclusion, how to perform lap liver surgery safely? The answer is to follow the leaders and learn from their mistake and don't do the mistake again. Optimize your own technique and device. As you know, followers will never know how hard the leader tries to create path. Thank you for your kind attention.
Thank you so much, Professor Ravisak, for your wonderful technique and presentation as always. Okay, I think, Dr. Papa, we got a lot of the laparoscopic liver surgery technique experience from many liver surgeons, right?
Yes.
And
Agree.
we should get this time to improve our technique and learning curve in laparoscopic liver surgery, starting from the left side.
Yeah, sure. It's principle. Yeah. I'm really appreciate the webinar, and it is really good to young surgeon or student like us. This webinar is really invaluable.
Okay.
Yeah. So, shall we continue to
Q&A sessions? Yeah.
Okay. So now all the speakers already presented their talks, and all are very important and really essential to know before you laparoscopic liver resection, and it is really beneficial to scleral surgeon or young surgeon like us. So before we go to the Q&A session, I find some pioneer endoscopic surgeons as well as senior surgeons and yet some young surgeons are attending, and we are really we feel favored, and we are also very glad to see them attending this webinar. So before we go to the Q&A session, may I invite some pioneer endoscopic surgeons to give some comment to us. Okay, Dr. Moon?
Okay, Dr. Papa, please go on.
Yeah, so actually endoscopic surgery was started in Myanmar in around about 2004 or something like that, and Endoscopic Surgical Society of Myanmar was founded in 2009, which was led by pioneer surgeons Dr. Win Yin, Dr. Yen Yin, and Dr. Tiso, all are professors. I'm really sorry that Professor Yen Yin passed away already, but there are still two pioneer surgeons, Professor Win Yin and Professor Tiso. So I would like to invite Sayadi Win Yin, Professor Win Yin, give some comment to us and to give some encouragement words to proceed our laparoscopic HPP surgery. So Sayadi Win Yin, could you open your video mode and mute please? Sayadi, are you with us? Okay, I'm really sorry that Sayadi Union is not in accessible area now. So may I invite Professor Tu, who is the current President of Endoscopic Surgical Society Myanmar. So, Sia you kindly open your video mode and hand please. Could you give us some comment to us? Please do a favor to us.
มีถามอะไรจ่ายว่ามีถามอะไรจ่ายไปด้วยคำถามมีใครบ้างอะไรเป็น not to
I'm really sorry.
It's
Really
okay.
sorry for that.
It's
Actually, the accessibility or some technology are not really keep in touch with us. That's why I'm sorry. So, Dr. Luke, shall we proceed to Q&A session?
Yes, of course. And if your senior staff surgeon was ready to comment, please let me know. Okay, I will follow for the Q&A session.
Okay, thank you.
Waiting.
Thank you for your
Okay.
guidance. Okay.
Okay.
First question, Dr. Luke.
Uh-huh.
Please go ahead.
Yes. Start from the first questions. Okay. How should we control bleeding in laparoscopic liver resection? I think I'm not sure this question from Dr. Okay, but
ต่อไปเลยนะ
however, I think the breathing is very important and a big obstacle when we perform the laparoscopic liver resection. We have to manage the bleeding in laparoscopic precisely before we can go ahead to complete the laparoscopic technique. Many techniques start from you can apply your instrument to meticulously dissection to see where is the bleeding point, is the hepatic vein or from the pedicle, with the slowly move to not further injury to other organs. And then when you know what is the origin of bleeding, if the bleeding is from the hepatic vein, you just put to compress it slowly. I think it can be controlled. And the second step, maybe you can ask to the anesthesiologist to control the CVP low. It will help you a lot to decrease the flow of bleeding from the hepatic vein. And then you go back to see the intraperitoneum pressure. If you still got low the pressure, maybe you can slightly up for the pressure a little bit to control the hepatic vein bleeding. But in the other hand, if the vein is bleeding from the pedicle, maybe you just you have to evaluate that pedicle is for the specimen that we will remove from the body, or the pedicle is the specimen that we have to keep it. If it is the specimen from the specimen, just clip it and leave it out. In other hand, if the bleeding from the pedicle is from the important pedicle, you should to slightly to suturing with meticulously. But I think the trick is calm down for yourself first, for the starter or the junior staff like us. Just calm down first and then just meticulously dissection. I think it will be passed. Okay, how about for the next questions.
The next question is, how can we know the anatomical variance in patients? Which investigations are mandatory? So this question is talking about anatomical variance. So I'm sorry, Dr. Lu, could you have some answer to the
Yes, of course. I think we can know about, we should know before the operation in every patient about the anatomical variance of the patient and the investigate in my institute we selected for the CT scan triple phase or the MRI upper abdomen with Primovisc. It will help us a lot about the variation of portal vein, hepatic vein or bile duct, especially in MRI upper abdomen with Primovisc phase. In the Primovisc phase, we can trace to the bile duct anatomy in exactly what is the variant or is it have or haven't the variant. And how about you, Dr. Papa? What about investigation of choice in your hospital?
Yeah, I have similar opinion with you. So we start the CT abdomen and have CT abdomen first, and sometimes we can do spray with CT contrast and then CT only. But most of the cases we need MRI liver and MRCP. As you already explained and mentioned about it, of course, bile anatomy is more better to see in MRI, and then we can see the some small intrahepatic metastasis or lesions in MRI. So start with CT and then we proceed to MR. Yeah.
Furthermore, in my institute, Dr. Chairat, he has the master of the liver volume analysis with the before in mostly major case, major liver resection, we will use the MRI to create the liver volume analysis to evaluate the future liver remnants of the patients and important anatomical variant in the patient before the operation. That's why we will got less complication or morbidity in patients.
Yeah.
Okay.
Really nice, really nice. Thank you for your answer.
Let's continue to the next question.
So next question is from Dr. Tinuda. She's senior surgeon from my department. She asked us, her question is, we have to consider FLR quality and tumor clearance in liver cancer surgery. So in case of type C or type 3 vein variation, how can we safely do left hemihepatectomy without compromising right portal veins? So I think this question is asking about left hemihepatectomy. So should we ask Dr. P for that?
Dr. P?
Dr. P, could you do a favor to us?
Okay, can you hear me?
Yeah, we can hear you clearly.
Yeah. In the type C, the portal vein is the anterior. You mean the anterior from the anterior segment to the right, join to the left, right?
Yes.
Sometimes I think we have to, if the depend on the tumor. If you do the colorectal surgery in the left side, so you can preserve. If the resection margin is safe, you can preserve this vein and duct. But in the hilar cholangiocarcinoma, sometimes we have to cut the tumor at the hilar region or the you have to sacrifice the right vein. So before you do, because you have to know it before you go to the surgery. So you have to calculate the future liver remnant first. If it's not enough, you have to PVE and then sacrifice it if it need. Or FLI is not inadequate, you have to PVE first.
Oh yeah. Okay. Thank you, Dr. P. So Dr. Lu, what about next question?
Okay. Move on to the next question. Which 3D reconstruction software or radiology software is used for preoperative assessment and liver volume calculation? I think I have one man that master in this. Please, Dr. Shairat.
Yeah. My choice.
Okay. Can you hear me?
Yeah, we can hear you well.
Okay. About the program, you can use whatever you have in your hospital. Mostly, the program came with a CT scan machine, so can use whatever you have. Is not different about the program. In our institute, we use Vincent from the Fuji to make a 3D reconstruction. Because of our CT machine, we cannot use their program, so we do by ourselves. For the calculation, we have another program that called OSIRIX. We can calculate this by the hand drawing. It takes a time, but if you have a good quality of the CT scan, you can use in the Vincent for the 3D reconstruction. Thank you.
I think it's very useful when you perform the preoperative evaluation, OSIRIX or Vincent, right, Dr. Shairat?
Yes, but it's not necessary. If you have the other, and you can use them wisely, you can use whatever you like.
Thank you for your answer. Okay, Dr. Papa, how about the next questions? I think we have many questions. We have to hurry up.
Yeah. I think a lot of people get interested in our webinar and topic. So the next question is, in non-contraceptionectomy, you prefer whole left radical flow control instead of controlling from gate 2 to gate 1. What any advantages? I think this question belongs to Dr. Chera. So Dr. Chera, please, could you do us a favor?
Yes. Can you hear me?
Yeah,
okay.
Can hear you well.
For the case that I show, if you see the picture, the patient got a quite cirrhotic, so we don't do the prickle maneuver in this patient. We want to preserve the flow to the right side, so we select on the left side. And for the question about why don't we access to the gate 2 and gate 1? In some case, the pedicle is embedded inside the liver. Sometimes it's not easy to control from the laparoscopic. From the open, sometimes if you mobilize the left liver, it's maybe easier, but in the laparoscopic, maybe it's difficult. So in the case like this, you may control the whole pincle or the only one side of the left side. It depends on your condition of patient. Thank you.
Yeah, thank you, Dr. Gerard. So, Luke, should we proceed to next question?
And the next question is, do we need to check light posterior bile by ICG or intraoperative cholangiogram, right, before cutting left pedicle? Is that need? I think Professor Ravisak, can you answer us for this, because you have many experience in laparoscopic way. Please,
Okay.
Professor.
Okay, thank you. I think it's necessary to confirm only if we use the technique of Christian. As you know, Christian approach, we may injure the structure inside the Christian sheath. But the way that the answer that if we transect the pedicle above the hilar plate, I mean at the level of second order branch, so we can avoid the violation inside. So I think the same way if we apply Christian approach, every time we transect the major branch, we have to transect above the hilar plate in the same way. So the answer that not necessarily to confirm, but you should have the special technique.
Okay. Thank you so much for your answer. It's quite clearly to do or don't. Okay. And for the next question, Dr. Papa.
The next question is it easy to open the arranger's way to get posterior wall of left airway in patients with large tumor? Which retraction method do you use? I think this means arranger's first technique in left hemiparectomy, I think. So, Professor, Dr. Rafifa, please, can you explain, can you give some answer to this question?
In addition to get posterior border, I think, did you hear me?
Yeah, we can hear you.
In my case, presentation, sometimes it's difficult to expose all the laryngeal ligament. So I recommended to only apply the endobrock clamp. Just when you dissect a little bit to see the posterior border of the left portal pedicle, just only see this border you can apply to do the pedicle control. Not necessary to, because if you track the tumor will spillate in the vein, because the hepatocellular carcinoma likely to invade to the vein. So I not recommend to retract it directly. So just control, just use a tickle technique. You can see it can identify the demarcation line, and then you do the liver parenchyma and you can control all the pedicle or the left pedicle control.
I would like to add up. In case of large tumor, it means that we cannot flip the segment 2 and segment 3 to the right. So it's impossible to see the junction of the of the left portal vein and laryngeal duct. So it's not easy to encircle the left portal pedicle. So in that case, I not recommend to do like this. Okay, you just Pringle maneuver and parenchymal transection first to encircle the pedicle. It's safer. Is my recommend.
Thank you, Dr. Rafifa and Professor Rowisek. Really appreciate your answer and thank you. So, shall we proceed to next question?
And how can you control the portal pedicle in type C portal anatomy? Portal pedicle in type C anatomy.
I think it is already answered. Shall we move to the next question?
Okay.
I think quite similar.
Yeah. And for the next question is the concerning left hepatectomy in case of bile duct abnormality such as one right branch joining the left duct. One right branch joining the left duct. Okay. What would be the consideration for the right duct branch, especially in laparoscopy. I think it's already answered too.
Yeah.
Okay,
Same,
maybe
same.
the next one.
Quite similar, yeah.
Okay, let's see now. If the question is, if we cut the segment 4 pedicle, will the segment 3 become ischemia? Left median sector containing segment 4 and 3, also in Brisbane terminology.
Segment 4 pedicle. Will the segment 3?
I'm not sure about the meaning of the questions. I'm so sorry, but how can you ask me live about? Because I think if it is quite separate from the segment 4 and 3, right?
Actually, Dr. Meeting is senior surgeon from our department. This morning he told me that the difference in terminology of sector and sector. He told me that if we consider portal vein territory and portal vein distribution, left medial sector contains segment 3 and 4, and left lateral sector contains only segment 2. And if we think about arterial anatomy, left medial section contains segment 4A and 4B, and lateral section contains segment 2 and 3. He told me like that. Maybe this question is concerned about that anatomical terminology, I think.
Okay. But he is not Professor Meeting. He's not here, right?
It's okay.
Okay. And another question is, what are tips and tricks while dissecting hilar plate not to injure the hilar structure? I think it's already answered. Is that clear?
Yes.
Okay.
Yeah.
And is there any advantage of low lithotomy position over just slit leg position? Slit leg or slit.
I think maybe she wants to talk about split leg. Split leg. Split leg.
Oh, split. Okay. I think it's low lithotomy and split leg. I think it's not. I think it has an equal advantage for the surgeon who mastery on the middle of the patients. It depends on because when in our institute, when we do the position like low lithotomy, I think we've got the obstacle things when if we upside reverse Trendelenburg patient, I will got the problem that the legs of the patient will obstruct to the floor and maybe limit the position that not high enough. Maybe some tumor location in the superior or the anterior surface or superior part. I think the position will be the important one. If you can up the head of the patient more enough, the location of the tumor, we can encounter it easier, I think. But the advantage, I think, is same.
Yeah, same. I agree. Yeah. Okay. So can I move to the last question?
Please.
Yeah.
Is that the last question?
The question is, in case of intrahepatic dissection, when using middle hepatic vein as a landmark, when the dissection plane is too close to middle hepatic vein, can it be injured? So middle hepatic vein damage during the procedure, how should we tackle? So I think Professor Rovi said, could you do a favor to us?
เนี่ยนะถามอะไรนะ
Intra-hepatic
Intra-hepatic
when the dissection plane is too close and it begins
when okay that I told you there's two methods to approach the major vein inside the liver. So the important point that first you have to know the anatomy, the variation of the vein before you perform surgery. And the second is you have to master the dissection device. Myself, I usually use Cruza, and I master it a lot of case, a lot of time. So there are two ways. If we move from the root to the periphery itself, avoid avulsion. But in case if we move from the periphery to the root, not recognize the small branch and make an avulsion injury to the vein. And if you have injured the vein, if it is just a side branch, you just compress it. But if the injury is split type, may got a big problem. Some case can stop by compression, but some case need suture. Okay.
So actually, I want today in this today's webinar, a lot of young surgeons also attending this webinar because they get interested in laparoscopic liver surgery. So may I invite Professor Tuntiama to explain how to control the intraoperative bleeding during laparoscopic liver resection based on the principle of laparoscopic liver surgery. Mark, do you do a favor to us?
So for the bleeding control, so you have to control the vertical pass, and then you have to cut transition line. So if you keep on the transition line, you will be the less bleeding. Okay? And when you get the parenchyma, you have to use the energy device properly, which is the very important one. Don't be rushed. And then you have to control the bleeding properly, and then you further decision. This is the important one. Otherwise, your field of operation will be the larvae shape, and then you can't see properly. It is a very dangerous one. Okay? So if you do properly, I think you can avoid the major hemorrhage. Okay? By doing that, you can find the vessel properly, you can dissect properly, and you can control the vessel with the appropriate measure, like the tape or like the hammer or stapler. You can stabilize the vessel and you can control the vessel properly. Okay. There is some injury. You have to calm down, and then you just press the vessel bleeding point, and then they just wait a few seconds or minutes. You have to prepare what instruments you have to use. Are you suturing, or are you using the diatomy, or are you using the bipolar? So, but you have to think of where is near the major vessel or just the branch. So if just the branch is okay, but the near the major vessel, on that time you have to ask the anesthetics. First, you have to increase pressure for about 14 hours, just for the temporary period, and then they remove the gauze, then they find out the vessel, and then they apply the appropriate technique, diatomy or clipping or suturing. Sometimes if there is massive bleeding, on that time you have to ask the anesthetist, just remove take off the ventilator for the few seconds, and then they will find out the bleeding, and then the suture. To be the quick, before you do these things, you have to take off all the things where we are, where is the bleeding vessel. You have to prepare before that, and then you have to do. I think this is my answer. So, is there anything you want to add up?
sorry for this difficulty in communicating with all of you. It's my pleasure to listen to all the speakers who give a very clear view of how to do laparoscopic liver selection. In our ESS days, we are doing laparoscopic surgery on GI tract, but we haven't started laparoscopic liver surgery until Professor Tintema has taken up the head of the department of liver surgery. She introduced this laparoscopic surgery. It is a nice session to be with you all and to listen all the clear views how to approach the level of the liver for the initial phase of learning curve. What I want to ask is, it is perfect to have a inflow control as well as outflow control. But I think it is rather difficult to do outflow control for the initial phase of learning curve. And how can we overcome the problem of outflow control? Outflow control for the initial phase of laparoscopic surgery.
Professor Louisa, could you do us a favor to us?
Okay. Good evening, Professor Winmia, right? Winmia. Okay. The answer is that for the inflow control, I think it's important and it's easy to perform. But outflow control itself, I think, is danger and it's not necessary in laparoscope because we have we call medical control. For example, we use anesthesiologist technique, anesthesia, to make a low CVP. We have a pneumoperitoneum. So in my sense, low CVP and pneumoperitoneum is itself already control the outflow.
Can hearts help in the outflow control and assisted laparoscopic for the initial phase?
The anesthesia will make the CVP low. It's important. And also airway pressure is too low too. This is the help from the anesthesia.
Yes, you have beautifully shown the highlight dissection and then the control for the hepatitis. It is a very clear and very effective identification of the left portal branch and the distribution and the line of resection by the control of the pre-hepatic control, that is at the left portal control in your video. This is a very, very fascinating procedure. Is there any measures to prevent the biliary leakage from the liver resection raw area?
I think prevention.
Biliary leakage.
I think prevention is important. Prevention by meticulous technique, and in the last step, we usually use a white gauze to compress the transection plane to test the bile leakage. If we found only small leakage, we usually use a coagulate device. But if the leakage is big one, we may suturing or clip. So I think prevention is important and meticulous technique selectively creep and divided is important.
Thank you. So thank you everyone for very active discussion on this subject.
Thank you, Siaji.
Thank you.
Thank you.
So, look, now time is running out. So, shall we proceed to closing speech? Could you invite Dr. Jinma?
Okay. So we continue to our last session, and I think we know a lot for the laparoscopic liver surgery, starting from the left side from many liver surgeons and from Myanmar and from Thailand. Okay, and we got a lot of technique which will be a good time for learning and improve our learning curve and our technique from many experts from this webinar. And I think Professor Jinma, please give us a closing speech from this webinar. And I think it will be not the last webinar. It's gonna be many times. And because of this is a webinar series, right?
Yeah.
Please welcome Professor Jinma.
I would say today is a great day because of this great event. As we all know, laparoscopic liver resection has proved some safe oncological benefit with the additional benefit. So patients are very happy with their scar for their liver resection and rapid recovery. And in this webinar, we learned about that is how important is anatomy, and then all speakers point out the landmark and the anatomical view in the laparoscopy technique. These are very important. Thank you so much. I would say thanks to the Professor Wawisak and team from the National Cancer Institute and my team from the Young Specialty Hospital for a series of webinars for diffusion of laparoscopic liver resection in our country. I also thank the electronic team from the Thailand and Myanmar side for help to make this series of webinars happen. We would love to continue this webinar series. As we said, now we start from the left, and then we will move to the right and difficult situation. I'm definitely sure Professor Lewis will guide also in future. Lastly, not the least, I do say thanks to all participants and all speakers and all moderators from Thailand and Myanmar side. And finally, I wish all of you stay safe and wealthy during pandemic time. Thank you very much.
Thank you very much, Professor Jinma, for the closing speech. Thank you very much, Professor Jinma, for the closing speech. And may I invite everyone to turn on the camera for our good photo, please.
Sorry,老乡，有人做不到，
ไม่ได้ยินนะ Okay. What's the Tintin? This is the photo session. Yeah. Please wait for a while. Please turn on your camera, please, and wait for a while. We have a lot of participants. We can wait for a while.
1, 2, 3, smile please. And I think we should have another photo shot together again. Let's do again. Okay, all right. Ready? 1, 2, 3. Smile, please. All right. Thank you, everyone. We come to last but not least. May I? Yeah, you will see the feedback form at your screen, and please give us the feedback form. Thank you very much, and good night for everyone.